الله وكفى والصلاة والسلام على الحبيب المصطفى ما بعد. Today I will be gonna talk about myeloproliferative disorders as a continuation for our previous lectures. Last lectures we talk about chronic myeloid leukemia as a proliferations, white blood count, basophil, eosinophil. Myeloproliferative in general, it includes polycythemia, FERA, ET, essential thrombocythemia, CML, chronic myeloid leukemia. Already we talked about CML previously in the last lectures, in addition to primary myelofibrosis. So today we will talk about polycythemia with ET, with primary myelofibrosis. We will start with the polycythemia. Our objectives for this lecture is to understand the physiology mechanism that regulate erythropoiesis, recognize the secondary and primary cause of polycythemia, understand the clinical pathological features of polycythemia vera, and also recognize how it's important genetic study in the diagnosis and management of polycythemia vera. In addition, we should cross over to essential thrombocythemia and primary myelofibrosis. So myeloproliferative including CML, chronic myeloid leukemia, polycythemia vera, ET, and primary myelofibrosis. Major category of neoplastic proliferation of white blood count, we have the myeloid neoplasm, we have a lymphoid neoplasm. In this lectures, we will talk about myeloproliferative neoplasm alone. In general, MPN صوت متداخل، في صوت آخر معنا. بالله اللي معه أو الهوست يقفل المايك. MPN it's an abbreviation for myeloproliferative neoplasm. So MPN features هنا يتكلم عن ال CML، يتكلم عن البوليسيثيميا، يتكلم عن ال ET، ويتكلم عن ال primary myelofibrosis. All of them together, they are sharing the same features, including cytosis. Cytosis means increasing in the number of the cells, regardless, could be hemoglobin, could be white blood count, could be platelets, organomegaly, male splenomegaly, high uric acid, bone marrow. Usually they are a hypercellular bone marrow, and eventually they will be progress to acute leukemia, mainly acute myeloid leukemia. Myeloproliferative neoplasm, according to WHO 2008 myeloproliferative neoplasm. طبعا there is a new version في 2016 في a lot of classifications. It will be including chronic myelogenous leukemia اللي هو PCR APL1 positive، واحنا تكلمنا عليها اللي هو فيلادلفيا كروموسوم، عن فيلادلفيا كروموسوم. polycythemia vera mainly حيكون عندهم JAK2 mutation. If you are looking للميلوبروليفراتيف تلاقي JAK2 mutation common تنعاد عليه كثير، سواء مع البوليسيثيميا مع البرايمري مايلوفيبروسيس او الاسينشال ثرومبوسيثيميا. الكرونيك مايلوجينوس لوكيميا يوجد جينيتيك ميوتيشن عندهم هو البي سي ار اي بي ال اللي هو كروموسوم، كم الرقم حيكون؟ ترانسلوكيشنز
19 to 12 دكتور.
كم؟
19 to 12
لا
أو 9 to 12
9 to 22 9 22 ها اللي هو قلنا فيلادلفيا كروموسوم اسمه. طيب برايمري مايلوفيبروسيس حيكون في JAK2، حيكون ايضا another 2 mutations في شيء اسمه CAR reticulin اللي هو يسمونه CRL in addition to the MPL mutation. والفورث things اللي هو essential thrombocythemia, platelets count will be elevated وحيكون usually they have associated with JAK2 mutations. Another category called myeloproliferative neoplasm unclassifiable، بس تعرفون الاسم انه في another category called myeloproliferative neoplasm unclassifiable، لكن اهم شيء اللي عندي الفور كاتيجوري اللي هو السي ام ال، البوليسيثيميا فيرا، والبرايمري مايلوفيبروسيس والاي تي. CML ما حيكون عندهم لا جاك 2 ولا MPL ولا الكلار. البوليسيثيميا والبرايمري myelofibrosis والessential in general 90 to 95 they have a JAK2 mutations. في البوليسيثيميا فيرا البرايمري والاسينشال حيكون عندهم JAK2 around 50 لكن they have also MPL وكلار according to their distribution usually ranging between 20 to 25. Polycythemia in a creek, it's too many cells in the blood, means increasing hemoglobin. Usually, polycythemia it's increasing the hemoglobin or hematocrit. Usually they have absolute increase in total body red cell volume or masses. Usually, it's manifested as increase in hemoglobin or packed cell volume. Hemoglobin above 16.5 or 18.5 gram per deciliter in a woman and men, respectively, means female usually above 16.5 gram per deciliter will consider polycythemia, and men's usually up to 18.5 gram per deciliter will consider them as polycythemia vera. زي ما تكلمنا انه الانيميا usually في المن's threshold it's usually higher than the women's. Also for polycythemia threshold for polycythemia it's it will be low في women's and usually 16.5 gram per deciliters. This is the regulation of erythropoiesis. First, the oxygen carrying or there is a reduce the hemoglobin, and this will lead to the stimulus, reduce oxygen carrying capacity, send signals, kidney will release erythropoietin. The erythropoietin will give us signals to the bone marrow to release more erythrocytes from the red or formations, more erythrocytes or produce more erythrocytes from the bone marrow, and this will lead to the increase in oxygen carrying capacity, and this is a circle how it's relative stimulus. Usually polycythemia, it could be a primary, it could be a secondary. The primary usually from the bone itself, secondary usually another factors. It's secondary, it could be from hypoxia, it could be from cancers, it could be from others. Like in the usual primary, it's genetic somatic mutations. It's happened during after his delivery, so يصير لهم somatic mutation أثناء النمو وأثناء الحياة العمرية للشخص، يصير له بعض الجينيتيك changes وبالتالي يصير لهم increase في red blood cells يسمونها primary polycythemia. لكنه في secondary usually it's treatable، لكن البرايمري also كمان you can control it لكن you cannot cure them. Okay, classification of polycythemia. احنا تكلمنا على secondary polycythemia انه there is underlying cause، وفي البوليسيثيميا فيرا اللي هو البرايمري. Primary polycythemia حيكون في increase في red blood cell mass due to malignant proliferation from the bone marrow itself. يسموها neoplasm. كانت previously they don't say could be it's a neoplasm لكن finally they say the neoplasm it's a cancer. It can lead to the AML eventually. Secondary polycythemia, it's increased red blood cell due to a high erythropoietin level. Examples: COPD, obese, you have to look it for sleep apnea, ممكن يكون عندهم. Smoking, high altitude, high affinity hemoglobin, renal disease, some certain of erythropoietin secreting tumor like parathyroid adenoma. A lot of things can cause polycythemia, secondary polycythemia, and this is the reason the workup for polycythemia. First, you have to start with underlying cause of secondary polycythemia to exclude any secondary cause for polycythemia before you'll go to the polycythemia vera. Sometimes ممكن تلاقي شخص عنده relative polycythemia that this could be a normal. Why? Decrease the plasma volume. واحنا عرفنا والله polycythemia it will be increased في الهيموجلوبين والهيماتوكريت. صحيح ولا لا؟ لكن لو شخص عنده هيماتوكريت لو relatively فحيكون عندهم increase في الريد سيل ماسز، نسبة وتناسب الريد سيل حتكون أعلى من الهيماتوكريت، وهذه عادة تحصل نشوفهم relatively إنه يكون في شخص dehydrated لأنه فقد البلازما فوليوم، يكون عنده relatively الهيموجلوبين مثلا 16.5 من واحد elderly ودخل dehydrated، فبعد يوم يومين أو بعد أسبوع proper hydration تلاقيه improving his plasma والهيموجلوبين تلقاه حيرجع للنورمال رينج تبعه. Polycythemia, it's a clonal myeloproliferative neoplasm. It's a hematological malignancy characterized by excessive proliferation of erythroid. طبعا احنا تكلمنا على المايلويد lineage، ممكن يعطينا الريد بلاد سيلز، ممكن يعطينا البليتلس، وممكن يعطينا الوايت بلاد كاونت mainly النيوتروفيل والايزينوفيل والبيزوفيل. و this is the reason لما نتكلم اليوم هنا CML تكلمنا عليها قلنا في increase في الوايت بلاد كاونت، ومينلي حيكون ايضا عندهم increase في الايزينوفيل والبيزوفيل. اذا اليوم احنا حنتكلم فقط على polycythemia which increasing في الإريثرويد precursor، وبرضه في الاي تي حنتكلم عن الميجا كاريوسيتيك precursor elements في البومر والبيوتيز. Diagnostic features: hemoglobin 18 more than or equal 18.5 gram per deciliter في المن، الwomen's 16.5 gram per deciliter. بومرو usually they have a hypercellular بومرو يسمونه pan-mylosis. All the three elements of hematopoietic will be increased. نتكلم عن الإريثرويد والمايلويد والميجاكاريوسيتيك. They have a JAK2 mutation more than 25% of cases. At the same time, they have a low serum erythropoietin level. How to differentiate between polycythemia secondary والpolycythemia vera هو erythropoietin level first. الإريثروبويتين play a major role في البوليسيثيميا، بالتالي لما يكون عندي polycythemia vera neoplastic أو hematological malignancy حيكون الإريثروبويتين level low، لكن لو كان في secondary حيكون high or at least normal الإريثروبويتين لأنه it induces or stimulates البوليسيثيميا circle. Clinical features of polycythemia: first, increase of blood viscosity. حيكون عندهم hypertension، حيكون عندهم headache، حيكون عندهم dizziness, visual disturbance, paraesthesia. Thrombosis: they might have a DVT, might have a myocardial infarction, mesenteric, portal, splenic vein thrombosis. In general, they have a higher chance to get thrombosis. Splenomegaly: 70% of people they will get splenomegaly, and 40% they will get hepatomegaly. So it's organomegaly in general. So they have increased blood viscosity, thrombosis, with organomegaly. Also, they have erythromelalgia, which is a common. You can see it, and sometimes after they taking a hot showers, they will have a pruritus, polycythemia. So make sure after they get the hot showers, you have to ask him about any pruritus or erythromelalgia. In investigations, in general investigation, CBC showed increased red blood cells, mainly hemoglobin. White blood count platelet, it can be elevated, but it's not usually. Will be high or sky high. Usually it will be mild elevated. The blood smear, peripheral smear, it will show in excess of a normocytic normochromic red blood cell, in addition to a leukocytosis or thrombocytosis. This is a peripheral blood smear. You can see it how it's the red blood cell close to each other. Also the platelets, if you can see it, this is the platelet dot. It will be more than usual we see it. This is the bone marrow, how it looks like. And if you are looking for the bone marrow, this is considered a hypercellular. بالعموم hypercellular compact bone marrow. But this is a hypercellular bone marrow. طبعا البلو stars here, it will be erythroid precursors. حيكون عندهم predominant erythroid precursors. Also will be increasing في الميجاكاريوسيتيك أو الميجاكاريوسايتس والمايلويد precursors. With time, they might have polycythemia increase the blast count, or they will go to the AML transformations or leukemia. طبعا هو كاتب لك AL transformation هو ال AML transformations or leukemia transformation. Complication and treatment. Diagnosis of polycythemia vera. تكلمنا عن diagnosis of polycythemia vera. You have to start with the simple non-invasive workup. You have to start with erythropoietin. You have to make sure this is a polycythemia. Then how to differentiate between polycythemia vera and secondary. You have to do further workup. You have to start with erythropoietin. Erythropoietin high or normal. You have to look it for the underlying causes. إذا كان COPD, you have to do pulmonary function test. إذا كان obese, you have to do a sleep study. إذا كان cancer, you have to do a CT scan to look it for any cancers, adrenal, liver, thyroid cancers. A lot of things you have to consider to work up for a secondary polycythemia. If it's low erythropoietin, this goes with polycythemia vera, then you have to do JAK2 mutation, which is a molecular testing through the blood, draw the blood and send it for JAK2 mutation. It takes around 1 to 2 weeks to get a final result. Then you have to confirm with the bone marrow aspiratum biopsy. Once you have a diagnosed polycythemia vera, then you have to consider treatment. The first treatment will be a vein sections. اللي هو ايش؟ تبرع بالدم. ايش الاذر نيم؟ فلابوتومي. فممكن الشخص هذا يتبرع بالدم vein sections or phlebotomy plus aspirin. Aspirin will be considered an 81 ppb aspirin will be considered the basic things you have to start it. There is a lot of myelosuppressive drugs like hydroxyurea. Certain indication for myelosuppressive drugs. In general, you don't need it. If he's a young, less than 60, he did not have any atherosclerosis factors, بمعنى he did not have any MI, ما عنده DVT قبل, not diabetic, aspirin it's enough in addition to the phlebotomies. لكن لو كان المريض more than 60 أو he had diabetes or hypertension or myocardial infarction previously or a DVT, then you have to consider to start hydroxyurea. Started with the 500 milligram BID. 10 to 15 years, around 20% of people with polycythemia vera will goes to the myelofibrosis, and around 10% they will be transforming to the acute leukemia. This is in general overview about polycythemia. I don't need to go in details about polycythemia, like you have to do treatment first. It will be a phlebotomist plus aspirin. Even though الكلام على هل يستفاد من الفلوباتوميز في الناس البوليسيثيميا فيرا، ممكن نستفيد منهم يتبرع بالدم، هل ممكن انه ننقله لمريض اخر؟ في كلام كثير حوله وفي جدل. بالعموم في كندا اتكلم يتبرع ما يستخدم للتبرع، وانس انك انت تعمل فلوباتوميز يرمى، ما يستخدمون لانه عندهم اكتفاء، لكنه ما في اي اشكاليه. في كثير من الارتكل تحدثت there is no problems لو انه واحد مثلا تبرع بدم وهو كان عنده بوليسيثيميا، لانه الكلام كله على انه جينيتيك ميوتيشن في البون مارو مش في الريد بلاد سيل سيركيوليتنج. البرايمري myelofibrosis وقلنا they will have a JAK2 mutation, MPL mutation or CALR mutation. البرايمري myelofibrosis with a long term، طبعا انت حيكون في البوليسيثيميا they have a proliferations mainly. على اللونج تيرم حيحصل فايبروسيس للبون مارو اتسلف، حيحصل بدل ما يكون في انكريز في الريد بلاد سيل وايت بلاد كاونت بليتلتس، حيحصل العكس، حيحصل لهم مايلوفايبروسيس في البون مارو اتسلف لانه استنفذ البون مارو او استهلك البون مارو. It's a clonal MPN characterized by proliferation of megakaryocytes, granulocytes في البون مارو that are associated with deposition of fibrous connective tissue and extramedullary hematopoiesis. With the long term, they will have fibrous connective tissue replacing the bone marrow, and they will go for extramedullary hematopoiesis in a state of the bone marrow itself. Usually again في البداية ممكن يكون عندهم cytosis زي البوليسيثيميا زي ال-AT، لكن later on with the long term they will have anemia, leukoerythroplastic blood pictures, massive splenomegaly, fibrotic bone marrow during the bone marrow aspirate and biopsy, JAK2 mutation, polycythemia more than 90. هنا حيكون JAK2 mutation around 50%. Risk of AML transformation will be slightly higher than the polycythemia, or they will have a 20%. If you remember previously we did talk about the peripheral blood, how it looks like the myelofibrosis. حيكون عندهم ايش؟ حيكون عندهم teardrop. واضح teardrop. This is an example for my
واضح.
bone marrow في myelofibrosis. This is a normal bone marrow. If you remember, this is a bone marrow in the polycythemia rubra. We don't have any fatty cells. It's compact bone marrow. Here it's a normal bone marrow. This is a cartilage or bone. This is a fatty cells, and this is how it looks like the cells in general. This is a fibrosis. Usually they have a sheets of fibrotic bone marrow. You couldn't determine what is the erythroid or megakaryocytic or myeloid elements. The stages for primary myelofibrosis, there is a pre-fibrotic stages. The pre-fibrotic stages حيكون عندهم proliferation في الميجاكاريوسايتس والجرانيولوسايتس. I mean here for granulocytes اللي هو البيزوفيل والزينوفيل والنيوتروفيلز, and they will have a leukocytosis or thrombocytosis. Okay, for 7 to 10 years survival حيكون عندهم. الفايبروتيك ستيج حيدخلوا في مرحلة إنه replacing البون مارو itself، حيكون في fibrosis. البون مارو itself حيكون عندهم anemia, leukopenia, thrombocytopenia, extramedullary hematopoiesis. This will take around 3 to 7 years survival, so around 10 to 15 years, and then eventually will be AML transformations with less than or equal 1 year survival in general. ال-AT اللي هو essential thrombocythemia, platelets count usually 450. They will have JAK2 mutations. Again, ال-AT usually, not each one he had the platelets above 450, you'll say this is an AT. Sometimes you can see it to people with 700, 750, relative thrombocytosis. وتكلمنا عن relative thrombocytosis. ممكن يكون post splenectomy, ممكن يكون عندهم iron deficiency anemia, ممكن يكون reactive infections or inflammation they will have. They will have elevated platelets count temporarily, but for AT usually it's more than 1 million. بدل ما تكون 450,000, more than 1 million, you have to raise the concerns about AT in this scenario. AT, it's MPN characterized by marked bone marrow megakaryocytic hyperplasia and the peripheral blood thrombocytosis. Features of AT usually sustained thrombocytosis more than or equal 450. Sustained, it's not a temporary thrombocytosis, hypercellular bone marrow with a megakaryocytic proliferation. Under the microscope, you'll see it more or a lot of megakaryocytic cells in the bone marrow. You have to exclude the CML, اللي هو chronic myeloid leukemia, polycythemia vera, primary myelofibrosis, وال-MDS اللي هو myelodysplastic syndrome. Exclusion for all of these ينطبق على البوليسيثيميا وعلى primary myelofibrosis. When you are having concerns for primary myelofibrosis, you have to exclude the other MPN, each one. حتى في البوليسيثيميا when you are doing البون مارو دائما يكون عندهم BAM myeloses. This is again it's the primary myelofibrosis. BAM myeloses معنى عنده increase في الميجاكاريوسايتس, increase في الإريثرويد precursors والجرانيولوسيتيك. لكنه في المايلوفايبروسيس they will have a sheets of reticulum, sheets of fibrosis تكون موجود. الJAK2 mutation is around 60. If negative, you have to consider to locate there is no evidence of reactive thrombocytosis. وتكلمنا عن reactive thrombocytosis. iron deficiency anemia, splenectomy, surgical infection, autoimmune disease, all of them, they can cause reactive thrombocytosis. This is how it looks like ET. You can see it, a lot of dots, small dots. This is an AT. This is a bone marrow. This is a fatty vacuoles, and this is cartilage. Part of its لو تلاحظون انه الاريثرويد usually it's erythroblast usually it's blue dark. في الميجاكاريوسيتيك it's towards the plaques more, لكن usually its shape will be different. This is megakaryocytes, 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 megakaryocytes. They will have increased megakaryocytes in general. Clinical manifestation: 50% of people with AT usually they are asymptomatic. They are at risk for thrombosis, risk of bleeding. Despite increase of platelets, they will have a chance for thrombosis and also bleeding. Mild splenomegaly around 50 and mild hepatomegaly around 20%. In general, you have to know MPN can cause cytosis, can cause thrombosis, can cause organomegaly. Very indolent disease. Usually they have a 5% risk of AML transformations. Treatment, the same polycythemia, you will have to consider aspirin plus minus hydroxyurea. ما تكلمت على other new modalities for treatment. لو حصل failure في الهيدروكسيوريا, you have to consider another medication. It's called JAK2 or JAK2 kinase inhibitors. A lot of medications الآن in the era of MPN they are using mainly في آخر 10 سنوات. واحدة من أكثر الإكزامبل اللي هو روكسلينيتينib. If you have a hydroxyurea failures, you might consider roxlenitinib. وأيضا you might consider a clinical trials أو transplant. If he's a candidate, you might transfer him for a transplant. If he's transformed to the AML, you have to consider to treat him like AML with a chemotherapy. This is slides about JAK2 mutations. JAK2, it's a non-receptor protein tyrosine kinase inhibitor involved in the signal transduction pathway. Usually it will be at codon of 617. غير مطالبين بمعرفة الكودون, لكن we have to know pathway mainly for MPN. It's a JAK2 mutation, and this is the reason احنا لازم نطلب دائما JAK2 molecular testing. لو واحد سألك ليش تطلب الJAK2, لأنه المين mechanism for MPN it's JAK2 mutation mainly. It could be MPL or CALR, but usually the JAK2 mutation it's the commonest things في polycythemia mainly, around 50% في AT و primary myelofibrosis. غير مطالبين بس للفائدة فقط JAK2 mutations mechanism. هذا وصلى الله وسلم على محمد. فيما يخص المايلوفيبروسيس انتهينا منها. واضح الكلام؟